closed. There is going to be coffee and tea and some sweets left in the back as the day goes on, but we're going to be setting up lunch over there and we don't want to disturb. So welcome everyone. My name is Michelle Dennis. I am the COC Unit Director at CARES Inc. I'm literally just opening up today, and I want to introduce Dave Warren, who is the Services Director for Community House. Thank you, Dave.
Thank you, Michelle. Thank you to CARES for hosting this great event that we have here today. And thank you to all of you for coming today. We're really excited to have Dr. Gill here to discuss the intersectionality of domestic violence and HIV. And we're really excited to have this grant from HUD and VAWA to create a best practice in our community and hopefully replicate that for other communities in our, across the state, across the nation, really. And it's just an incredible opportunity, and I think we have a lot of energy behind this really important initiative, and I'm really looking forward to the work that we're going to do here. So thank you very much, and thank you for attending today, and I really look forward to the day that we'll share together. Thank you, Michelle.
Thank you.
Hi, my name is Denise Joyne, and I'm the lead for the House of VAWA project at CARES. I'm so glad to see everybody here today, so thank you for coming. And I'm going to introduce Dr. Gill, who is a professor of medicine at the University of Calgary. And like Dave said, he's really done a trailblazer in this area of the intersection of HIV and infant partner violence. So we're super honored and excited to have him here. Dr. John Gill.
Thank you for inviting me. I ought to admit this is a bit of a high-risk activity for me because I'm talking to a room full of people who probably know a lot more about some of these areas than I do. But on HIV, I'm fairly well informed, so I'm going to come at a discussion for the HIV treatment angle. Because I belong to the University of Calgary, I have to give my conflict of interest. Give advice to a variety of drug companies, and I've received grants from anyone who'll give me money. That includes the NIH, Gilead. I even got some money in euros from the European Union and from some universities through subcontracts. Because I'm part of the University of Calgary, I have to admit my political lobbying. And that has been to the extent of telling my city councillor that our downtown bike path sucks. It's bad for health and it's bad for the environment. It didn't change the vote, but at least I felt really good I was politically motivated. But that's about as far as I go as a good Canadian on political lobbying. So I'm going to give a little bit of how I got into this field and how things have evolved from a personal perspective. First of all, I have no personal experience of intimate partner violence, childhood abuse, or homelessness. And my rather testy mother and grandmother would have said, how can you talk on this? You don't know anything about it because you never experienced it. Well, I have no personal experience, but I've looked after a lot of people. And right from the day I graduated from medical school, I've been a strong believer that if you have a good team with you, it makes much more fun for everyone. And it actually really improves patient outcome. And in nowhere is that more important than in complex social medical issues. One of the leading complex social medical issues, at least for the last 30 years, has been the HIV/AIDS pandemic that's affecting all of our countries. Now, my background is very traditional. I trained in internal medicine, subspecialty in infectious diseases, which I still practice, and if you have flesh-eating or tuberculosis, meningitis, I'm your guy. Hopefully you don't have that because those often don't do well. I have a university appointment, and my university appointment wants me to basically earn my keep by seeing patients. But then they say, oh, because you're a university appointment, you can use our logo, you've got to teach and do research. And that can be a little bit of a cross, but also can give a lot of fun. It allows me to come here and talk. Now, when I trained and finished my infectious disease training, it was like, I don't know if you've seen the Far Side cartoon of this deer that has a huge bullseye on its chest. And all these hunters are chasing it with bows and arrows, and he's saying to the fallow deer, "Bummer of a birthmark, eh?" Well, I finished my infectious disease training in 1984. What was happening in both our countries in 1984, the AIDS epidemic was exploding. Now, in my area, I had one boss who said to me, "Well, I'll support you looking after HIV AIDS, but I will not put myself at personal risk by looking after those people with self-inflicted disease. But I'll support you doing it." Also, I had one colleague who sent the residents in to examine the patient while he stood with his hand on the doorknob, waiting to run out if something amiss should happen. Well, I actually believed in the facts and believed I was not at personal risk from contracting HIV because it's really bad form to have sex with the patients or share needles. And so I took on the HIV portfolio because it fitted with terrible, serious infectious diseases that I feel comfortable doing the best we can in managing them. And I thought it was a really neat group of people who were very needed. And it's been a wonderful ride in personal growth. So for the first 20 years, it was no drugs to treat HIV, then one drug that didn't work well, two drugs that worked a bit better, more recently, drugs that work really quite well. And I've been dabbling with better drugs, resistance, how you manage resistance, and how, even in Canada where you perceive we've got limitless resources for healthcare, how you measure value for money and how you measure what are your outcomes and where there are problems in your program to address those flaws. Which will bring us to where we are today. So back in 2009, I was sitting thinking, what am I going to do? The drugs are really very good. My career's I'm still mid-career, I don't want to finish. But I want to do something meaningful. And I don't consider looking at a cholesterol-lowering drug that gives you 2 micromoles less low density cholesterol than the next. Is that exciting? I prefer I've been in really exciting medicine. What was I going to do? And I was sitting looking at this graph that tells you, and probably gives you much the same of what you've seen in your area. This is the number of patients living with HIV diagnosed in southern Alberta. And we get everyone because of universal health care. If the government pays, which they do, you go to see one program. No private doctors, no university doctors, one program. And this shows how our epidemic has grown up to now close to 1,700 patients. And this shows whether they're on 4 drugs, 3 drugs, 2 drugs, or they're on a treatment break for whatever reason, or no drugs at all. And as you can see, our epidemic has expanded, but also the number of people on treatment is still very, very good, it's high. But we have an interesting group from the research point of view. Why, when you've got free drugs and everyone is suggesting treatment for everyone, but we got down here, this little group at the bottom, why have we got patients who are on either no drugs or on a treatment break? I mean, it's kind of interesting. You and I know if you had HIV, I'd be on drugs immediately, and I would take them, and I'd do well. But why have we got people in 2017 not on them? Just a little research question I was thinking about. I was looking at the immunity, which in HIV is the CD4 count. And if you look at our program, we have now 26 patients with a CD4 of less than 75, which is terrible immunity. 26 patients out of 1,700. In 1989, we had 28 patients out of 200. So the drugs that we're using are improving the immunologic health of our patients, but not everyone. I was looking in 2009 at my deaths, and this is a really encouraging graph that shows in blue, these are the deaths from AIDS, and in red are the deaths from other things such as hepatitis, lung cancer, liver cancer, violence, bacteremias, endocarditis. And as you can see, the drugs, those use of the 3-drug regimen from 2000, whatever, has diminished deaths significantly, but we've still got a background of people dying, mainly from non-AIDS defining events. All these were going on in my brain at the time, thinking, well, am I going to have to move off to do TB or something, or do I keep in HIV? And another area that I've been pursuing that we're thinking of is cost. And my program budget is $30 million for treating 1,700 patients on drugs. I spend $1 million on a program, which includes social workers, nurses, and some lab tests. The money in HIV is in the drugs, and as more people go on treatment, the cost of the drugs goes up, and we're now up, as you can see, the cost of drugs is going up, but the benefit is we have very few people who are not immunologically suppressed. So, all of these things are going on. Drugs work well, my drugs are free, I don't have to worry about reimbursement, everyone should be on them, 83% of my patients are doing fabulously well. I've got the lowest number of profoundly immune-compromised patients in 20 years, so I'm not managing TB and HIV or Cryptococcus and HIV. I've still got a few number of small deaths. So really, the buzz has gone away. What are we going to do? This is not exciting any longer. And then I started watching the local news. And about the time I was doing it, my pager went off, and I looked at it, I recognized that number, put it on, still, oh, what's going on here? My pager went off, another number. Well, that's what brought me to be here today. One of our patients that everyone knew in our program, a delightful lady, had been killed by her common law partner in what to everyone in this room would be extreme, brutal domestic violence assault. Now, the pager was going off because the media were trying to track me down, the police were trying to track me down because police do not like blood from HIV patients. They go berserk, they think by looking at it, they're going to catch HIV. And they needed reassurance and counselling. My clinic staff were paging me saying, have you seen the news? And then also we got the media saying, you know, what's the risk of people from blood spot in HIV? So this was very traumatic. It came on the background of me thinking, what am I going to do with all this? You know, my patients do so well. How can I really make a difference? And the next morning I nipped in early to pull the lady's chart. And she was, from my point of view, as an infectious disease specialist, a complete medical success. She had drugs that she liked, that she took without ever missing a dose. She had normal immunity. Her cholesterol was fantastic. Her kidney function was good. We'd done her bone densitometry, as HIV docs love to do. Her bones were strong. Her immunization, she'd even been immunized against pneumococcal vaccine. She'd had everything. So she was a John Gill HIV success. But then I got this kind of feeling, but she's dead. Like, what's medicine about? Is it keeping a CD4 good, or is it about living longer? She was dead. She died on my watch and in my care. And then this was a kind of, I gave these slides an epiphany. Well, I could have walked away and said, well, I treated it. I treated the virus, I suppressed the immune system. What more do you want? I'm an infectious disease doctor. I also thought, well, do I want to get involved in this any further? Because I've done everything I'm trained in, and if I'm not going to get involved, how am I going to do it? And one strategy that many of my colleagues use is, not sure I've got the resources, I don't have a team of people who might know something about this. I prefer to manage with viral loads and CD4s. My patients will tell me if they've been abused. They'll cough it up. They'll tell me if they think I've got anything to offer. And that denial approach and it works if you want it to. Don't ask, don't tell. I think that's been used down here as well, that approach. Another approach we dabbled with is, well, are we going to re-injure them? And there was some distant literature. You've got to be careful asking people about bad things that are going on in their life or that happened a long time ago because you could re-injure them. That actually hasn't, in the long term, held up as being a compelling argument. Something you need to be a little bit aware of, but it's not a compelling argument not to address an issue. Another thought I had is, I don't know anything about this. And what do I do with it? I've got no resources to deal with it. Well, actually that's not true, but I didn't know who the resources were. So I could say, well, they'll tell me if they need to. I'm going to stick with my CD4s and my cholesterols that I'm really comfortable with. I don't want to re-injure them, and I don't know what to do with it anyway. Another approach that could be used is, well, I'm an infectious disease doctor. It's family docs. They're much better at that. Let's pass it off to someone else. They're better equipped to deal with the issue. And of course, that isn't loved by the family docs who say, John Gill sitting in a multi-million-dollar hospital with teams of psychiatry, social work, and he thinks me in my private office is going to be better at this? That doesn't go over well. I thought about, well, I'll start asking a few of the patients I think look as if they're a bit beaten up. But then I had a panic. What do I do if I ask them? And they say, oh, I can't believe what's going on. So all these thoughts were going on. I've got HIV's doing well, but I've got patients dying in care that we're seeing every 4 months. I don't really know how to tackle this. Well, because of all the press and because of us in the clinic knowing this lady extremely well, next morning we had an urgent team meeting, and I'm sure you guys have team meetings. In Canada, they're called the group hug. We've been traumatized. Someone we actually really like has been injured, and we'll need a bit of mutual support because this shook everyone, including myself. You need a bit of team support on this issue. And we went through the records, and we really didn't recognize that this lady had been in such extreme, life-threatening danger. And as we kind of started to commiserate and feel sorry, very sorry for her, and wonder if we missed something, there was a consensus from the team that as a mark of respect for this lady, we couldn't change the past, we could perhaps change the future. And the view was we needed, as caregivers to a well-described population that we see frequently, we need to make sure this wouldn't happen again. We did not feel that this was needed to go through any ethics approval because this fits within clinical care of people we see regularly to find out what's going on in their life, to make sure that we can deliver appropriate care. And so we thought we needed to find out urgently, well, how common was IPV in our program? It did not escape us that we would all not do well if there was another death similar to that in the next few months. In fact, I could say probably some people just have given up and changed their job because we'd seen one event and have to do something about it. So we thought we'd start asking, and we'd say, well, how is it impacting our patients? Asking about IPV, domestic violence, or abuse as a child is fine, but what's it actually meaning in their life? Is it meaning they have low self-esteem? Is it meaning they're insecure in their food? Does it mean that they're insecure in their housing? Does it mean they have mental health issues? Or they're being pushed into drinking, doing cocaine or fentanyl or whatever too much? So we thought we needed to ask everyone, is it common? And what effect is it having on you? Because clearly if it's having a very negative medical health effect, we need to address it because it's going to impact our medical metrics. As we mused around this, we thought we needed an operating procedure for coping and handling whatever we found, because I'm not into asking a question and saying, oh, now, what do I do now? This person's got an abusive parent or spouse, male or female. What am I going to do about it? We need to set up a process. So I thought, well, let's look into the literature. And yes, there's a wealth of literature on IPV in non-HIV, but HIV is a little bit different, because HIV will bring a patient back to us repeatedly, because if you don't adhere to medical care, you get sick. So it's a bit different, and the literature in HIV and IPV is very limited. Except we did find that IPV increases your risk of catching HIV, and when you have HIV, your risk of IPV goes up because of lower self-esteem, low self-value, disclosure, stigma, and everything else. So there's this term that's coming into evolution called the syndemic. So the literature on HIV and IPV was limited, but a little bit scary. So I work in a building that has a STI clinic above us, and above that, in the same building, is a sexual assault clinic, acute sexual assault victims. And so we wandered up there and said, do you have any survey that we could use? And they gave us the survey that we've used since then. I claim no proprietary interest to it. It seems to work fairly well. There may be better ones, but it's one that we had immediately available, that is validated and meant to be of use. And we started to screen our patients, everyone, as time was fit. And as we did this, we got a team of social work, and my clinic has 3 social workers, say, well, we find they're positive. I need telephone numbers and support network for addictions, food, housing, substance use, all of the networks that need to be out there if I find a positive answer. Because you're not helping if you ask a question and they say, oh, that's very simple. You can't do that. You've got to have, showing willing is good, showing, but you need actually a process to actually follow up on anything you find. So this was kind of a bit life-changing for me, having worried about viral load assays, CD4 and diversity. I was down to an area I had no familiarity with. And the next thing is, I did not realize that the scientific literature is domestic violence or intimate partner violence is actually, I thought about sexual, and I thought about physical, as happened with our patient, but there are several domains. There's physical abuse, sexual abuse, emotional, psychological abuse, neglect, isolation, intimidation, and financial. And there is well-established definitions and pertinent examples. Because, okay, someone says something nasty to your spouse and they catch you because you put the garbage out. That doesn't really fit the criteria, but on the other hand, if it's repeated, nasty, associated with kicking, biting, whatever, that certainly does meet the definition. So when we were asking, we needed to figure out ourselves, so when we asked whether this fitted the scientific definition of domestic violence. And those are on the handouts. We've got lots of, they're just well-established criteria. So, almost immediately after the demise of my patient, we started screening everyone in our program using the screening tool that I mentioned and the definitions that are out there in the literature. And that was another shock in my life, whereas I thought some of my crowd had bad things happen to them or had bad things happening to them. We found that using this criteria, 34% have disclosed domestic violence as an adult or a child. And I must admit, this shocked me because I had not had a single patient in the previous 15 years of my career ever say to me, you know, actually I'd have one, ever say to me that they had bad things going on at home. Now, I looked into the literature, and in my province it actually has a higher rate than some of the other Canadian provinces. It's about 22%. So in HIV, the HIV has got a higher risk of IPV than in the general population. Since we opened the program, 9 patients have been removed the same day that we asked the question. Because in all good conscience, we could not let them go home when we found out what was going on. We only found out this by asking. These 9 that we said, we need to get someone to pick up your stuff from home and we'll put you into one of our shelters where you will be safe. We could not let 9 of our patients go home because it was a life-threatening environment. So this, again, one experience led to a whole cascade of events. Now, I wondered, well, wow, that's an awful lot, 33%. What else is out there? And in other literature, in both the developed and even the developing world, the figure fits with other people's figures. About 20 to 50% have got a lifelong prevalence of IPV. So I felt as if I'd gone into the garden, there was a big rock that was perched precariously, and I lifted it up just to see what was under it and thought, oh, I wish I hadn't done that. Now there is in Canada, my population, we've got a lot of Aboriginal Canadians, North American Indians. The politically correct term now is an indigenous population. And they're a wonderful group that has some fabulous proverbs. And as one of my colleagues, who's an indigenous ID infectious disease physician, said, John, you can call them a proverb, sometimes you can call them a curse. So I surveyed my patients, and I found this figure. And these 2 proverbs are, knowledge that is not used is abused. With knowledge comes great responsibility. I mean, these really hurt, these 2. If you ask, you can't just do nothing about it. So I decided I better seize the nettle, which is what's brought me here, and some of the research that we've been doing over the last few years. So I found there was a lot out there. And you may or may not have seen such similar situations, but 2 things, I'm going to give you just 2. I've got a wonderful series of very sad cases that I've encountered when I asked. And I'll just give you why this has become important to me in my fight against HIV, because I need to know the root cause of why someone became such a dysfunctional individual, they won't take my wonderful pills the way I prescribe them to. Very frustrating if you're a traditionally trained IV doctor. You blame the patient, but you sometimes might need to know why the patient, they're not doing it just to aggravate me. There's a reason. And when I understand that, I'm far better at looking after them. So, patient A, I'll call her Susan. Susan is a 40-year-old female. She's had HIV for about 15 years. In that 15 years, she's taken HIV drugs for 3 weeks. Susan is 40, but she looks 70. She's got part of her scalp hair removed because of a bottle attack. She's got a history of multiple incarcerations. She's got some track marks. And she's got multiple scars from injuries, broken bones, pins, whatever. But occasionally I've seen Susan in the light. Wow, Susan once was really, really pretty. And as part of the history, we asked her, have you ever experienced domestic violence, abuse as a child? And Susan, when she was about 10, her dad died, and her mom shacked up with a guy who was far from pleasant. And she was abused by her stepdad and her uncle repeatedly. And at the age of about 12 and a half, she was desperately depressed and unhappy. And I'm sure you've all heard stories sometimes. And she's got some friends who, teenage gypsies, they looked happy. She was unhappy. Well, why are you happy? Oh, I've done cocaine. So she started cocaine, and the next 20 years of her life slipped into heroin, incarceration, prostitution, heroin, incarceration, hospital, heroin. 25 years of basically addiction, corrections, HIV, Hep C, the whole meal deal. Where did it start? She was being abused, she felt very unhappy, she had no one to talk to, and her friends doing coke at the time looked happy. Now, when I teased all this out, I'm far more empathetic dealing with this lady. The interesting thing is now I'm the doc because I'm the stand-up. I can't palm her off on anyone else to look after because at least I get why she's so difficult to deal with, and I just take her shit and we move on. I'm sure you've all seen this, but it really makes it a lot easier to deal with this desperately aggravating woman who won't take her pills every day, because I understand where she's coming from, and eventually I feel we'll make headway. If she's still around, we'll make headway because we understand each other. And patient B. Patient B is a 24-year-old male who transferred in from another Canadian province. And he looked, and the guy had been on treatment, off treatment, and he was a big-time drinker. 24, and he got significant cirrhosis, his liver was stiff, and he had transferred in, the intake team administered the questionnaire, which is fine, and hey, I'm a doctor, I can do this, it's my program. So, you know, I've got patients lined up every 10 minutes, the drugs look pretty straightforward for him, if you take them, we'll do fine. So I said, no, it's part of routine, we screen everyone, experience of domestic violence or childhood abuse, you know, because we believe it can be an important determinant of your health. Does any of that apply to you? Well, I then had to write off 40 minutes of my clinic time because the guy burst into tears, and I wonder why he became an alcoholic. He was being abused by his uncle. And then the question is, well, has anyone asked you about this before you can deal with it? No one ever asked. Well, it sure makes it easier to understand why this guy doesn't take his drugs is because he's drinking too much. And why is he drinking too much? Because he's got this horrible history from when he was a child. It fits. And when I got into this, all of a sudden I could understand why my problem children, as I call them, the ones who are going on and off treatment, or the ones who can't start because they don't want to deal with the HIV, it's because there's often, not always, but often, a rather grim history that maybe needs to be discussed if we're going to engage them successfully in care. I'm sure if you've asked, you've all uncovered similar sort of episodes to these guys. So, as we started to look at our figures, we've got about 33, 34%, depending on when I slice my data, including childhood abuse. Some were abused as a child, as an adult, and there's a significant overlap. Women were higher than men, but our indigenous Aboriginal population is very high, and that comes back to a very dark period of Canadian history, which we call the residential schools, where the Canadian, in case you don't know, the Canadian government scooped kids out of their homes and put them in a residential school to educate them, and unfortunately, very bad things went on. So when they returned back to their homes years later, they had been seriously injured. To my surprise, although the trigger for our study had been a man-woman, HIV, or at least domestic violence, is not just a gender thing. We have some really nasty stuff going on in our gay community, and most of the work that I do has been strongly supported by the Rainbow Coalition, our local AIDS group, who say, In gay culture, it's fine, but there are some really dark aspects, and this needs to be explored further. And we also found it was common in our injection drug users. Of interest, in Canada we have a fairly free immigration policy, and we do take Africans and Indo-Asians with HIV. We don't exclude them necessarily because they have HIV. And the prevalence in those communities is low. I suspect it's low because often they believe or perceive what is normal in their culture to not meet my criteria, which is something we're exploring a bit further. So that's something that needs to be worked on. So men, women, indigenous populations, and needle users is where my big action is. The next thing we did is I mentioned all those domains. Well, unfortunately, it doesn't really surprise us. It's not just one domain. Many patients are abused physically, they're abused sexually, isolation, neglect. And if you look in a sort of overlapping Venn diagram on the right there, you can see that some have got overlap with multiple domains of abuse going on. So we have a high prevalence, higher than the general population. It's multi-dimensional. We've got some populations particular risk. So why is it so bad in HIV? Well, the literature says being abused means you're depressed, you have low self-esteem, you may have no self-value, you may have mental health issues, and as part of an escape mechanism, you undertake activities that put you in risk for HIV. Risky sexual activities, maybe men, women, men, whatever. Substance use, that all increases your risk for HIV. And that is not just in developed world, it's actually in the developing world, where we found that domestic violence in the developing world can increase your risk. I wondered if I was unique and that Calgary was just a terrible epicenter for domestic violence. And absolutely not. We are no worse or any better than anywhere else. A sad comment, perhaps relevant to elsewhere, is a leading HIV program in Canada knew of my work, and they said, well, do you have this? And they said, oh, we think we've got far worse than you. And I said, what are you doing about it? I don't know what to do. We're doing nothing. They'll tell us if there's a problem. Someone from that program actually ragged on one of my residents at the national presentation saying, aren't you worried you're going to re-traumatize them? And the answer is absolutely not, and I've got data to prevent that. That was a cop-out because they're too lazy, too scared, not interested. Sorry if I sounded judgmental on that. Okay, so it's common because HIV fits into the syndemic that you deal with in the general population. Domestic violence, stigma, homelessness, mental health, substance use, criminal associations, jail, more homelessness, more food insecurity, more mental health issues. HIV is just part of a little extra circle, a cycle, that feeds off the social malaises that every society has.